Welcome everyone to today's webinar. I'm Molly Gamble, Vice President of Editorial and Editor-in-Chief of Becker's Hospital Review. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We're looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it's now my pleasure to start today's webinar by introducing our presenters. Wayne Frangish is Chief Human Resources Officer for UW Health, where he leads overall administration, coordination, and evaluation of the Human Resources Department. He is responsible for areas including talent acquisition, HR information systems and service delivery, organizational development, compensation and benefits, employee relations and performance management, and employee health and wellness services. Wayne began his career with UW Health in April 2017, bringing over 20 years of healthcare HR experience. Prior to joining UW Health, Wayne served as the Senior Vice President of Human Resources for Wheaton Franciscan Healthcare. Philip Musgrave, MBA, CPA, is a manager in UW Health's Enterprise Analytics Department, leading efforts around pricing, patient financial modeling, external data submissions, and other exciting work. Philip joined UW Health in 2012 and has had many opportunities to lead teams in the financial and administrative space, most recently on projects relating to predicting revenue and cost accounting, performance improvement, and productivity. Prior to joining UW Health, Philip spent most of his career with Epic, developing and implementing finance, accounting, and administrative systems. Steve Lothrop is Managing Director with Prism Healthcare Partners, a national healthcare consulting firm. Steve has more than 20 years of experience helping hospitals and health systems optimize productivity and margins. He is an expert in labor management, particularly the balance of service, cost, and quality, physician relationship management, organizational structure, and corporate overhead improvement. Prior to joining Prism, Steve has held leadership positions at Huron Healthcare, the Healthcare Management Council, and PricewaterhouseCoopers, and he is Executive Director at Haywood Hospital in Massachusetts. Sachin Sharma, a director with Prism, is an experienced healthcare consultant with a focus on productivity management and delivering labor savings. A seasoned project manager, Sachin has helped providers across the country redesign workflows, eliminate inefficiencies, and identify and implement operational improvements. Sachin has designed all phases of product management systems and has developed tools to automate productivity tracking and support leadership decision-making. I'll now turn the floor over to Steve Lothrop to begin the presentation.
So the goal of today's webinar is to share how UW Health implemented a sustainable labor management program. Wayne Frangish will share some insights with those on today's webinar. We'll cover the framework of the program that helped overcome objections, how it created a system of accountability. We'll talk about who the primary leaders of the program were, and how data was used to build momentum, and how that data was translated into targets. Sachin and Phil will share in more detail the elements of the infrastructure program, and Wayne and I will wrap up at the end to discuss some of the likely pitfalls to avoid. Right now, I'll turn it over to Wayne to give us an overview of the University of Wisconsin Health in Madison, Wisconsin.
Thank you, Steve. Slide 4 can give you some background on who UW Health is and how we've grown beyond our historical Madison base to a more regional and national focus over time. Our discussion today regarding our renewed emphasis on effective labor management was certainly related to some tightening of the financials, but was really focused on having the organization well positioned for the future as we have recently updated our strategic plan that supports our ever-expanding geographic reach. We continue to balance many initiatives while not losing sight of fulfilling our mission to the community, which is rooted in excellence in patient care research and education. Go to the next slide.
Great, thank you, Steve and Wayne. So Wayne, I'm hoping you can kick us off today by expanding on UW Health's position in the labor market and the labor opportunities your system saw when it began working on this initiative with Prism.
Okay, when we began our labor review, UW Health had a strong labor market reputation that we feel we've been able to maintain throughout this work. We still have below average vacancy rates, really building off a lot of positives. We're a magnet organized system for our nursing excellence. We've been able to recruit really well from some exceptional schools affiliated with their university, both in pharmacy and nursing that are located nearby. And we were kind of ahead of the movement, moving to a $15 minimum wage to provide kind of family supporting jobs in the community. Our organization still has, this is really more about a cultural change for us, for our organization. And really that change started, we had really strong volumes in all of our settings, and we wanted to be proactive and not get into the position of having forced reductions and that impact that would have on our relationships with our employees and the community. The opportunity was for us to really rethink our approach and think about culturally what needed to change. Most of this is not unique for us at UW Health, much as the classic symptoms of the industry, often solving any new problems that came forward with adding a labor resource over time to address them. We quickly realized that our leaders had a wide range of understanding of how to manage labor costs, how to schedule and plan for seasonal variability. Some had a good understanding, and others had to challenge their current practices that they felt were working for the most part. Our standard practice, not unlike many in the healthcare industry, was to assume we were always going to be short of staffing we need, and therefore we'd automatically replace any turnover without a true position control or review process. Also, we were probably more focused on budget alone, which is not a bad starting position, but understanding how to flex staff with patient volumes over time, having policies that help facilitate those management approaches, and then in turn having some way to measure in a more reasonable time frame our overall productivity and daily or even shift by shift performance.
So, as Wayne pointed out, managing the cultural change was a critical aspect of navigating towards substantial savings. But the opportunity to improve labor productivity was in creating a disciplined approach to implementing goals and targets for each of the frontline managers, helping the organization's leadership support that process in a positive way. And from a practical perspective, there was an opportunity to get managers to think about labor productivity more often than once a month, creating a measurement system that presented data every 2 weeks or every day or even every shift has a significant impact on how labor resources are used. And in addition to that measurement system, UW Health needed a structure for making sure that managers were accountable for results. That is, for finding a solution and making it happen. A work group steering committee of functional leaders was formed to monitor action plans and meet with managers that may not be progressing based on their plans. The work group steering committee reported to the executive steering committee made up of senior leaders, including the CEO. The executive steering committee addresses any objections to plans and makes final decisions that couldn't be agreed to at the work group steering committee. So the chart on slide 6 shows the trend in paid FTEs from the inception of the engagement. The blue line shows the gradual downward trend of the number of FTEs. And as with all organizations, kickstarting this process is a real challenge, especially at the beginning. And asking managers to reconsider whether an open position needs to be filled or when that position has already been budgeted for was a new experience for managers. As the goals and objectives of the program became more clear through careful communication to the staff, as tools were put in place, as managers started to understand the productivity concepts, the strain on the organization started to diminish. And by the way, that solid line at the top of the chart shows adjusted discharges over the same period of time, which remain relatively flat. Wayne, is there anything else you'd like to add?
So the graph kind of gives a depiction of our journey over the last year, and to give a sense of time period, organization, we're a July 1 fiscal year, so this was our kind of our fiscal year snapshot, and it shows a better than 3% improvement over that year in terms of our paid FTE costs over time. For background, we had done some communication early that summer that we're going to be reviewing position requests more closely versus kind of the historic automatic replacement mode, and that new positions would be rarely allowed. We then months later announced a more formal financial sustainability initiative to focus on both revenue enhancement growth as well as a thorough overall expense review. Certainly within your organization, many of the thoughts that jump to labor and jobs when you hear that, jobs being lost. And when you say things like that, but we've continued to work on improvements and have seen significant results in other areas, our revenue cycle, supply chain, and the other areas that most organizations are constantly working on. We also communicated throughout a real goal and intent to let the natural attrition of turnover, retirements, staff promoting into other roles to be the main contributor to labor reductions versus what sometimes others do in just taking a flat percentage cut. The graph shows really a very deliberate effort over time to hold off on replacing some roles and a focus led and really role modeled by our nursing departments with other areas as well, but to flex down our staffing with our patient volumes. During that time, also driven by our nursing areas, overtime agency and travel use was reduced significantly.
Great, thanks so much, Wayne. You know, you mentioned UW Health wanted to really rethink its approach to labor management, and a lot of these changes that you made were cultural. Can I stick with you for a minute more here to explain what the labor infrastructure program is? I know it's the result of the desire to make those changes. Can you describe the program, how it is different from other traditional workforce strategies, and then why other organizations don't already have something like this in place?
So probably each organization has some iteration of what they think is their labor infrastructure program. Often that can be the annual budget process, which in some ways was even our history. There'll be more details later in this hour in terms of the elements of the full program by Sachin and Phil. But to really manage what is your largest element of your total cost structure and having a disciplined and timely approach and process is key. But beyond process, having full support and alignment with our senior leadership team for us was critical. Having a consistent message across all areas that when you start introducing elements that may include some form of a position control or position review committee overseeing every position request, then setting that expectation that staffing is going to be varying every shift and every day, and then developing some valid units of service to target your staffing levels. Positioning senior leadership to set that expectation of consistency and approach, and that all of us are accountable is a must-have element. I'll have Steve comment on the other areas.
So the more traditional approach is what I would call top-down driven. That is, senior leadership identifies what the targets need to be by using some sort of benchmark or a flat % reduction across the board. And those top targets are doled out to managers, and it's up to the manager to try to figure it out. How the target was developed is a mystery to the manager, though. And without that buy-in on the front line, those types of changes are really difficult to sustain in the long run. But it can be implemented very quickly. So the reason many organizations don't have a comprehensive program like this in place is because it takes time, it involves lots of stakeholders, and progress can be somewhat slower to develop for an organization that might need results right away. Next slide. The components of the program are listed on the left side of this table. The more traditional approach, using benchmarks, might address targets on an annual basis, and they're usually based on comparisons to national peers. The manager isn't aware of the specific comparison facilities, and they're told that the targets are somewhat directional. Some departments are prioritized based on the financial gap to the benchmark. Development of the benchmark is one time, and it really takes very little effort. The infrastructure program, though, reevaluates the target on a biweekly basis. While the target may be updated annually, internal performance targets are evaluated by the manager more frequently through management coaching. It's more meaningful to hold a manager accountable for a target that they created themselves versus a benchmark that was handed down to them. But the effort and engagement required throughout the organization to implement a systemic program like this is substantial. But the result is much more sustainable. The traditional approach takes less time to implement, but the hope of sustaining that level of performance is significantly less.
Thanks, Steve. So the labor infrastructure program you just described, you mentioned it takes more time to develop and involves multiple stakeholders, but as you said, it provides systems with more sustainable results than traditional labor benchmarking. Wayne, can you take a deeper dive for us on the business case for a labor infrastructure program and what those sustainable results look like?
Okay, we can forward to the next slide as well. So I'll reference the 5 elements listed in my comments in terms of kind of the business case for why. In healthcare, there's not many that have the luxury of revenue growth outpacing increasing labor and other expenses. Having the proper accountabilities and infrastructure can over time become a progressive instrument for really all levels of leadership. To prepare for changing volumes, having indicators that more fluidly help leaders react to volume shifts versus a retrospective look when it's too late to take action. All these points require us to be challenging ourselves to not add or hire a person today that would be the first position we would eliminate tomorrow if your business had some downturn and that has to become our standard. That discipline can reduce the amount of difficult meetings later when you're forced to tell a committed contributor that you no longer have enough work for them and you have to sever the employment relationship. Having to initiate some form of forced staff reductions because as leaders or the combination of HR and your position review or just organization at whole didn't hold ourselves accountable is just really beyond unacceptable. And ultimately we have failed that employee who at times may have left another job to come work for us. We use the term accountability a lot in this presentation in the workplace, but actively or actually leading with that accountability and alignment is not always easy. At times the accountability may feel like it's shared or seen as it's a finance or HR thing to keep under control in the budgeting process. Finance and HR can support this process, but the hiring leaders must feel a personal ownership that each position they request to be recruited for. Transparency in the dialogue throughout develops more of a belief in the validity of setting the staffing levels. Generating a schedule and staffing model that you have the confidence you can post on any unit and be able to explain so that your staff are engaged in interacting with leaders when changes either up or down need to occur. When jobs are potentially at risk or you decide not to replace a role that has been recently vacated, these can be management decisions that can fairly get an emotional response from the rest of the team. Having an open and thoughtful understanding of how the consistency of your program and process helped in decision-making can support the difficult conversations. Certainly in healthcare, leaders have a wide range of experiences and expertise in developing the labor plans, and having this further level of review avoids some of the areas having potentially more of a future job risk if that leader is not as experienced in this work. There is also then more supports in place to ensure we are hiring at the proper levels for the long-term needs of the organization.
Thanks, Wayne. So the thing to keep in mind is that this process is not one and done. Organizations need to constantly look at developing better controls and strengthening accountability for aligning revenue and expenses. Organizations can always get better at and need to get better at anticipating changes in volume, finding new techniques for aligning staff with volume changes, standardizing how that process works, and baking those changes into a formal education program. So all the institution's managers are doing it the same way. The process is continuous. Organizations can avoid having to make short-term corrections in labor staffing the more frequently they keep productivity issues top of mind. Let's look at the next slide and I'll show you what I mean. So in this example, organizations A, B, and C are all implementing the same labor infrastructure program. Organization C has less time to realize savings because their financial outlook is uncertain. Their margin is not supporting required capital improvements. They need to immediately improve their performance, and the culture of the organization can't keep pace with the change the financial environment is demanding. The culture of that organization is more likely to be negatively impacted by the speed of change, and a low percentage of managers will be engaged in the process, and sustaining that change in the long run is really difficult. So organization A, on the other hand, like UW Health, is implementing the same infrastructure program despite having a favorable financial outlook and a healthy margin. But forecasts might show that the vision for their organization may demand a larger margin, or they need to be better prepared to withstand a negative healthcare policy change or some other potential surprise in the environment. Organization E revisits their labor management program, but they have more time to address their strategic needs, and because of leadership's foresight, they can follow a timeline that's less likely to have a negative impact on the organizational culture. That's why in the marketplace, we see financially strong organizations as well as less strong organizations addressing their labor infrastructure program. And even those strong organizations revisit their program frequently.
Thanks, Steve. And you had mentioned this is not a one and done program or solution. It's a continuous process. But I'm curious about the early stages of it. If we can talk a bit about the essential components of an initiative like this and how organizations can or should get started. So Sasha, can you talk about some of the core components of a best practice labor infrastructure program and then how an organization should approach implementing this system?
Absolutely, Molly. Could you advance to the next slide, please? In the following slides, Phil and I will go over the core components of a labor management system. Let's first briefly introduce each of these concepts. The PRC, or the Position Review Committee, provides a quantitative and qualitative approach to requesting new and replacement positions. This is really the foundation of the labor infrastructure program.
The second core component is that of a productivity monitoring system, which is a visual tool for every department to track their performance over time. Next, we need to have productivity targets, a process of creating department-level targets, leveraging frontline input and buy-in. Another core component we need to focus on is education. Putting in place a recurring process where existing or new leaders can be trained in the concepts of productivity and the use of the tool to monitor it.
Shift management tools allow departments to make real-time decisions based on current data. These tools help departments determine when and if to flex up or down staffing. Lastly, we have budgets based on targets. Incorporating productivity targets into the financials is very important to ensure everyone is managing to one number. This also drives accountability for the department leaders. Now that we have introduced each of these core components, let's take some time understanding each part. Next slide, please. As I'd mentioned before, the PRC, or the Position Review Committee, is the foundation of the labor management system. It provides a clear process for leaders to request new and replacement positions. Many organizations have something like this in place, but it may not be driven with both a quantitative and qualitative approach. A typical PRC meets on a weekly basis with membership consisting of a VP of HR, operations VP, finance representative, a nursing/clinical representative, decision support or analytics representative, and an HR business partner. On the next slide, you'll find a typical PRC process. This high-level overview outlines a clear process for requesting new or replacement positions, from the initial manager requisition to the VP approval or denial, and subsequently the PRC committee. It also provides a feedback loop to the department manager if the position is denied or we need some more information. I'd like to call your attention to the VP approval box in the bottom left corner. When a position comes to a VP for approval, the decision tree uses quantitative information out of the productivity tracker to help guide the discussion at this step. On the next slide, you'll see a sample list of questions a PRC committee would ask when reviewing a requisition. These are the same questions the VP should be asking during their review. Utilizing both quantitative and qualitative questions allows the PRC to get a total picture of the request. In the left column, you'll see a list of qualitative questions. These provide subjective background. You will see in the right column a list of quantitative questions. Many of these questions can be answered utilizing the productivity tracker, which Phil will now cover.
Thanks, Sachin. So the next core component we want to talk about is the process and tool for leaders across the system to monitor productivity. If we could advance to the next slide, please. So the productivity tracker is both a tool and the process, and we're going to cover 4 key aspects. First, it needs to be dynamic and interactive. We want to be able to drill down into information and slice and dice the data in different ways to answer different questions. Second, it can be tool agnostic. There are many different tools that could work in this space. Some examples are ClickView, Tableau, even Excel. However, whatever tool we select, it needs to be able to handle large amounts of data and be able to drill into discrete, actionable information such as employee, pay period, earnings code, etc. Third, the process needs to be flexible enough to accept information from disparate sources. While we want to do everything in our power we can to avoid manual data, we need to be flexible enough to accept it. Our process at UW Health pulled together information from multiple systems, including HR payroll, our electronic health record, as well as manual accounts, and we staged it in one central data warehousing repository. Finally, because the information in this tool often becomes the source of truth for FTE and productivity information and is used for hiring decisions, spending ample time upfront ensuring high levels of data integrity is really best practice. Moving on to the next slide, we'll see the main page of the productivity tool we developed at UW Health. All right, so we are looking at a screenshot of the front page of our dashboard with a few red boxes superimposed to direct your attention to selected key features, which we'll cover shortly. But to level set on the tool itself, at UW Health, we used an application called ClickView to build the dashboard. ClickView is a dynamic, web-based, interactive tool that allows a user to click or select information in the page to automatically adjust graphs and other information that's displayed. This tool is able to be used for the over 1,000 departments we have across our UW Health Madison operations. The backend data is stored in our enterprise data warehouse with just under 1.5 million rows of information, which encompasses just over a year's worth of productivity information. Users of the dashboard are able to tailor their view to suit their needs using the filters on the very top and the left-hand side of the dashboard, called out with the red boxes. Across the very top, users can highlight specific fiscal years, calendar months, or pay periods. Across the left side, users can filter on organization, leader, cost center grouping, or an individual cost center. Using these filters dynamically changes the information displayed in the graphs and tables in the middle of the dashboard. Finally, drawing your attention to the red box in the center of the slide, the 3 boxes display, if you could jump back one slide, thank you. The 3 boxes display paid FTE, target FTE, and variance for the current fiscal year so that the user can understand at a glance if they are performing favorably or unfavorably against their productivity target for their areas. Now, let's say I'm a nurse manager and I want to know more information about a specific department that rolls up to me and how that department's productivity has trended over time. If we could advance to the next slide, please. Clicking on the Pay Period Drill Down tab, highlighted in the top red box, we're able to see additional detail by pay period for a given department, which gives us an at-a-glance color coding to let us know how we're doing against our productivity target for each pay period. So using a silly example we like to use during our actual productivity education, during college, Sachin was my boss at Subway. And he said that for every 2.5-hour lunch shift that I worked, I needed to make at least 5 sandwiches. In productivity terms, that would mean that I would need to make 1 sandwich every 30 minutes or a 0.5 worked hours per unit of service. So let's break that down a little bit into the actual productivity formula we're using in this tool. My input is worked hours. In my example, it was a 2.5-hour lunch shift. My output is denominated in my unit of service, which is sandwiches. So in productivity speak, my productivity target is 2.5 worked hours, my input, divided by 5 sandwiches, which is my output, gives me a 30 minutes a sandwich target, or a 0.5 worked hours per unit of service target. Looking back to the screenshot of the tool, each row in the table represents one pay period for our emergency department, with the more recent pay periods at the bottom. You could see the color-coded column, column C, gives us an at-a-glance view of how we're doing using color. I want to drill into a few selected columns in the table and relate it to my subway example. Column A represents the unit of service volume for the given pay period. In my subway example, my unit of service was sandwiches. In this screenshot, the unit of service is emergency department visits. Column B is the actual worked FTE for the given pay period. In my subway example, this was my input, the number of hours I worked during my lunch shift, 2.5 hours. For our emergency department, this is the labor input in terms of the amount of hours folks clocked into the ED during a pay period converted to FTE. Column C is the column I mentioned before. We're calling this the productivity index. It's a visual representation of how the department is actually working in relationship to their productivity targets for a pay period, trending from red to green, showing an unfavorable to favorable variance. Finally, column D, that's our target worked hours per unit of service. In my subway example, my boss told me my target was 30 minutes a sandwich, or 0.5 worked hours per unit of service. Our ED's target is 4.7 hours per patient visit. Turning it over to Sachin, can you talk about how we figured out what our emergency department's target worked hours per unit of service should actually be?
Absolutely. Thanks, Phil. The productivity tracker is a great tool, but to utilize it to its best, one must create department-level productivity targets to measure against. When we talk productivity targets, we talk worked hour per unit of service, or WUPOS for short. Next slide, please. Multiple components and considerations go into target setting. For departments to buy into the productivity concept, we want to make sure the department targets are realistic and attainable. Target setting is a process. At UW, it takes on average 8 to 10 weeks to create a custom department target. These targets are built from the ground up, being sure to account for any unique circumstances. Let's use the ED for example. If we were to use a benchmarking approach, we'd assign a target of 3.9 worked hours per patient visit for UW. If we were to do this, it would not be successful, as there is no departmental input or consideration of what's different about UW's emergency department. A typical benchmarking target setting would not account for physical layout, their unique fast track approach, or the case management structure that's incorporated within the ED. Let's revisit Phil's subway story and compare a subway in an airport versus a college campus. The target at each of these stores would be different based on their unique situation. The airport location may have pre-cut veggies due to the lack of knives allowed beyond security, and perhaps a more limited menu due to space. For example, they don't offer hot subs. On the other hand, a college location may have longer hours of operation and make a higher volume of party subs. All of these items would impact target setting. Making sure we account for the differences and incorporate them into the target is what is important. I'll now turn it back to Phil to talk about the education component.
Thanks, Sachin. So we mentioned prior, the next core concept we needed to focus on was education, which was a recurring process we wanted to put in place where new or existing leaders could be trained in the concepts of productivity as well as the tool used to monitor it. If we could advance to the next slide. Because productivity can be a new concept for some leaders, we wanted to train as many as we could in person with a laptop or computer in front of them to achieve real partnering with every department. Classes consisted of 1-hour in-person sessions broken up into the following buckets. In advance of the class, we sent out homework that covered key concepts, calculations, as well as practice problems. Then, the first 30 minutes of class, we ran through a slide deck covering key concepts and reinforced learning, started with the homework assignment. The final 30 minutes were spent running through real-world examples and having question and answer with the leaders in the room. We also recorded one of our classroom sessions to create an online session where leaders who couldn't participate in person were able to sign up and complete the training in our learning development system. So in-classroom education was one type of education we did. We also did additional in-clinic/in-department education on another tool. Sachin, would you talk more about that?
Thanks, Phil. Shift management tools, commonly referred to as short interval time management tools, are necessary to implement and sustain the gains from a labor management infrastructure. Think of it as a real-time decision-making tool. Next slide, please. Using a shift-by-shift approach allows departments that have swings in volume to develop a more flexible approach to matching staffing to demand. Using this shift management tool in concert with the productivity system will allow one's organization to impact productivity at the front line. For example, at UW, we determined there's a relatively predictable flow of volume in our emergency department. We customized our schedules by day of week and time of day to match this flow. We then used a shift management tool to help ensure we're holding ourselves accountable to this plan. To further solidify these gains, we've matched our productivity target to our budget. Phil will now talk about this key component.
The final core concept is making sure that our budgets are based on targets. This is really the easy button for our leaders. How can we set up productivity so that there's only one set of measures to pay attention to for labor that also tie to budget? If we could jump to the next slide. At the end of the day, there's really two types of departments. A department whose unit of service is difficult to define. Those departments are referred to as fixed departments. Examples of fixed departments are finance or accounting, security, etc. Setting the productivity targets for these departments is straightforward. Their target becomes their budgeted paid FTE. Conversely, departments whose volume we would expect to vary with a unit of measure are considered variable departments. Examples of variable departments include nursing units, labs, clinics. The math here is a little more complicated. Here we use the productivity targets Sachin talked about earlier, multiplied against a forecasted volume for that department's unit of service, multiplied against a paid time off factor to calculate a budgeted paid FTE. Leaders then in these departments manage to their target worked hours per unit of service each pay period. There should be time at the end to chat about budgets based on targets if there are questions, as we've covered this concept fairly quickly. Molly, turning it back to you to cue up the discussion about critical success factors.
Thanks, Phil. So Wayne, I'm going to pose this question your way to get us started and then check in with your co-panelists here. But since you've really lived and learned by implementing a labor infrastructure system, what would you say are factors critical to success, and what are some pitfalls that you would advise colleagues to avoid if they pursue similar initiatives?
And my comments will be mostly on the success factors. Steve will comment on the pitfalls, and we'll try to hit all four of the lines of the slide here. Ideally, the tone is set from the top, having senior leader support and role modeling. In our situation, we had some turnover at higher levels in the organization, and we did not replace to send the message that this impacts everyone. It's important to understand that the cultural shift takes time, and leaders and staff are all at different spots along the way. When this work begins in earnest, it's very disruptive to your culture and your standard daily work. Many in our organization have only worked in this one environment in their careers. To gain some additional perspective, some external eyes on the work can be a consideration. We decided at that time to bring in Prism Healthcare Partners help gain some momentum, to understand where other systems may have had successes or setbacks, and then really to help us expedite the changes by supporting our leaders who already have busy work schedules. It will not be a perfect process on day one. Each incremental improvement along the way accumulates into others. You don't need to wait for perfection. Our labor cost curve slope was generated over a focus on daily results while keeping the long-term goals in mind. Supporting our operational leaders with education supported by timely data and making it safe to admit that they may not know how to do this work. They may have been doing for a long time without ever getting the proper training. From a human resources perspective, we were also able to leverage as a key resource our HR business partners. They already had the existing relationship with their respective operational leaders, and as a result, we're able to keep communications and follow-ups flowing more efficiently. This all while at the same time holding ourselves to a more systemic approach for consistency. And finally, communication needs to be a constant and targeted at all levels, including your physician groups along the way. Updating on the successes like employee cost-saving ideas that have been implemented and the challenges faced along the way are all key elements to be sharing.
Well, thanks, Wayne. I think what we see most often are those organizations that start to make progress and perhaps experience a month or two of better financial performance, not great, but better, and then decide that they no longer need to complete the course, that the implementation efforts are really necessary. So they take their foot off the pedal thinking they're all done, only to find out that what they thought was good financial performance was just normal variation. And they find themselves trying to reinstitute what they had started. The reaction from the staff then is that this is a new program and it's the new flavor of the month, that it's another initiative to be waited out until the next bubble of somewhat better financial performance makes it go away. But a disciplined approach stays the course, finishing through to the end, and continuously reinforces consistent messages around expectations for keeping productivity top of mind. And I'd add that UW Health did an excellent job of staying on message and being consistent, seeing initiatives through to the end. It was clear to the organization that a new way of managing resources was not going away, and that all managers had to develop new skills around managing labor resources differently. So before we finish today, I just want to address how to overcome some objections and gain buy-in at all levels. So the objective stated here is a bit romantic in the sense that you never really achieve complete buy-in. If you believe that you've overcome all objections, then your organization's resistance is just passive. It's moved underground, and you're not aware of it. There's always some reaction to change in every organization. It's how you prepare for it and how you manage it is the key to success. So here's the approach in two parts. First, clearly and consistently communicate the financial gap set at the very beginning of the project. The gap is a requirement of the institution. It's not a personal wish of any single individual. The gap is imposed on the organization by the financial environment. It's the result of changing policy or reduced reimbursements. Communicate that if we can overcome this barrier, the financial gap, together, then we can achieve our vision. It's plain and it's powerful. Secondly, as the work progresses, set and communicate expectations. One of those expectations is that managers are required to present their progress to the work group steering committee. Early on, it makes sense to have the most successful managers report out on their progress and to celebrate their wins. Having a VP acknowledge the win as a motivator for not only that manager, but also for all other managers. That is, the organization is demonstrating that the end result of personally changing something is better than the end result of not changing anything, and it's worth the hard work. There's a personal and public win for a manager who embraces this change. So clearly communicating the financial gap, setting the expectations, and publicly celebrating early wins are key elements of the productivity program. There are many other objections coming in all shapes and forms, but those obviously will be handled based on a specific situation. Next slide.
Okay, so what's next for us at UW Health? For us, it's really all about maintaining our focus. It's important that we ensure we have an organizational-wide accountability for ongoing success. This cannot all be on the nursing and other operational departments. The corporate and our other support areas must also be involved in filling that same pressure point, where it'll be difficult to feel this as a shared accountability over time. We'll continue to work on the tools and try to build in cost per unit of service, not beyond the hours. We've had a fair amount of skill mix changes over time, and we want to be able to quantify those impacts. And then to better incorporate the agency and travel use in more real time, make sure our data is as up to date as possible. But probably finally, and most importantly, it's critical that we hold the gains achieved. The position review process just never goes away. To have to come back after having FTEs creep back in and repeat the discussions would just cause a loss of credibility for us as leaders to our larger employee base. Now we'll transition back to our moderator, Molly, and we'll be open to any questions that have come forward during the presentation.
Thanks, Wayne. So panelists, thank you for that fantastic presentation. We're now going to begin today's question and answer session. For those listening in, you can submit your questions by typing them into your control panel in the space labeled "Enter a question for staff" and clicking send. We're going to try and get through as many questions as we have time for today. So Wayne, this first question is for you. Is meeting productivity targets a part of each department head's annual performance review? Is this also included with executive or senior executive's performance plan and/or bonus structure?
We haven't had it historically, and but it's an area that we're looking at in terms of setting goals for our financial viability goals and kind of incentives going forward. This is the first year we're really measuring, so we kind of want to get results so we kind of get a sense of a baseline and then potentially work it into more of our clear accountability structures in the review process going forward.
Thanks, Wayne. Phil, this next question is for you. Do you utilize quality and safety targets or performance in conjunction with productivity?
So we do measure quality and safety and have targets, but they're not in the same place as the productivity tool. So I think a next logical iteration of the tool is to include those additional types of measures. We're not quite there. I mean, we're really learning to, walk before we run. But I think it makes a lot of sense as a phase 2 or a phase 3.
Okay, great. And Phil, I'm going to stay with you for another minute. This question says, I really like your system because it is based on appropriate units of service and the department head will buy into the system. Do you compare your organizations to regional or national benchmarks? I think we definitely use benchmarking for certain groupings of departments. For instance, we use Action OI to help understand some labor benchmarking in some of our ambulatory area. So we do use it, but we don't necessarily have, let's say, something that can be universally applied maybe to every department from the same, I guess, benchmarking organization. But we do use them. I think, Sachin talked a little bit about this too in terms of how we go about kind of setting productivity targets for individual areas. We'll use as kind of one litmus test, a couple of maybe relatable benchmarks as a way to start the conversation. And then we really focus on tailoring, maybe because, we're an academic medical center and there's additional time required for residents, we'll build kind of unique, I guess, workflows that maybe don't exist in the, benchmarking data and kind of account for them. So we can make sure we're setting up a target that's reasonable and that we also have, frontline manager buy-in to. Thanks, Phil. Stephen Sachin, this next question is for you. What role did process improvement or process redesign play in this effort? Did UW focus on labor infrastructure only or process redesign?
This is Steve. A process redesign is a key component. And then using the example in the emergency department that Phil and Sachin explored, how the patient flows through the department is absolutely critical. What Sachin was pointing at were those elements of the emergency department process that makes the process unique here at UW Health and is actually generating the quality results that they're monitoring. So what Sachin was referring to is how do we preserve the best components of that process and then identify other activities that might be extraneous to that and may not be adding value. And that's really the starting point for improvement of processes in the ED as an example.
Great. And then Wayne, I'm going to circle back to you for a moment. How specifically do you hold managers accountable for this process?
We're still a little early in it, but I think it's first off getting trained on the tools and the understanding, and then having their leaders kind of work with them over time to achieve those results. I think it shows up certainly in the financials and your labor costs and all those things you normally are monitoring. But it's also just getting that comfort with work into your daily work, kind of this monitoring of how your staffing's going. So I think in many ways we're in different spots in different parts of the organization, but those who've gotten more comfortable with the tool and are monitoring more regularly, they're being managed by the leader as they historically have. And it's also now in our position kind of review process as new positions come forward. This is now an element that's part of that request in terms of how we're doing on these productivity standards versus just the budget, which is what historically was reviewed.
Thanks, Wayne. Thanks, attendees. We've seen a lot coming in, so we appreciate it. Sachin, this next one is for you. When developing a target with considerations for all the department-specific factors, how do you determine its accuracy? How do you prevent the pitfall of my patients are 2 times sicker in Department B?
So a lot of that happens when you're meeting with the department leader and kind of building that target from scratch. There's also always those issues that this or that, and it's really just taking the time to understand what it is and then account for it and how we build our target. For example, if we take Subway again, if I know I'm always making party subs and another unit is always making footlong subs, I know I'm going to have a little bit more time because I'm making a sub twice as big. Great. I understand that. In this unit, that's what we're doing. When we build our target, let's account that 50% of our volume is making party subs, and we're going to just add that factor onto it. So a lot of the minutia goes into understanding what the department is doing, what they're caring for, what they're making, and then building that up step by step in a reasonable manner with the department's input to get to a final productivity target.
Excellent. And Sasha, I'm going to stick with you for a minute. And Steve, I would invite thoughts on this question from you as well. How do you address concerns that quality will suffer if positions are not filled?
So in the sense of, I guess I'm not fully understanding the question. Are we saying quality as an overall organization or relative to a specific department?
You know, the attendee didn't specify, but it's just that concerns that quality will suffer. I anticipate that might refer to quality of care or quality out of departments.
So I think it goes back to when you set that department target and you're measuring and you set the target, making sure quality is a factor that's built into the target is where I would start. And then to Phil's point, making sure we also measure that along the way. And if we see a dip in quality, we want to know what is that related to. Typically, the first and foremost response is always saying it's perhaps labor related, or we didn't have enough resources to get the work done. If that's the case, and we go back, perhaps we have to adjust the target. If that's not the case, let's figure out what it is that caused that quality decline and address it and fix it going forward. Hopefully that answered the question.
Yeah, I think you make a good point, Sachin. The thing to keep in mind is that in a nursing unit, for example, we're not changing the model of care. We're examining the schedule that's developed by the nursing staff that's designed to deliver a certain level of quality, and that quality continues to be measured. What we're looking for are when there are diversions from that schedule. That is, times when you have excess resources and may not be aware of it. So the change in process is managing back to the changing volume and being aware on a short interval. When are those times when I've got excess resources? And at the same time, I could be using agency. And the use of agency, as an example, can have more of a negative impact on quality than anything else. Addressing when you don't need agency and making provision for not using agency has a better impact on quality. But managing the changing volume and being aware of when you have excess resources is a great opportunity to reduce cost and not have an impact on quality.
And I think the last thing I'll add to that, when we're making those targets specifically in a nursing unit, we'll have those nursing subject matter experts from our end working side by side with that department to ensure we are maintaining the quality standards within that department, but also accurately staff or appropriately staffing it as well. So just to reiterate, making sure that it is built into the target is very important.
Thank you so much, Sasha and Steve. We have time for one more question today. Wayne, this one is for you. Are you using the same position review and approval process for the clinics?
Yes, it's ambulatory and acute care settings it's the same process going forward and has been. And it's the clinics were already in many ways monitoring and benchmarking prior as well. So they were pretty quick to adopt and have been using the tools as well.
Thanks, Wayne. So that is all the time we have for questions today. I want to thank UW Health and Prison Healthcare Partners and the presenters, specifically Wayne, Phil, Steve, and Sachin, for their excellent presentation, and to our audience for participating today. Hope you enjoy the rest of your day, and we look forward to having you join us for future webinars.